I'm Pat Bradley, an otolaryngologist from Nottingham, England. On my panel, I've got Ezra Cohn on my left, who's a medical oncologist from Chicago. I've got Petra Ambrosch, who's an otolaryngologist from Kiel, and we've got Marshall Posner, who you've met, and Ricardo Hitt. I would like to start by saying, because most patients are deemed advanced disease, should we actually separate the T from the N in order to decide which we should treat? In other words, should the T be treated surgically, and should the neck be treated separately, surgically or radiation? Because we do see earlier tumours with large nodes. So in other words, do we actually have to radiate the primary as well as radiating the neck? Petra, what would you think?
I think this is a good question. It depends on how your treatment approach is in general. We are treating patients, if possible, with a partial resection. And laser surgery means partial resection of the larynx and the hypopharynx. And when I want to know whether a partial resection is feasible, then I must concentrate first on the T category of these patients. So this must be regarded separately. You are right that a patient with a T1, very small primary site, and an advanced neck metastasis, maybe, let's take the extreme, an unresectable, non-resectable N3 disease, then we should not regard the primary site and the lymph node metastasis separately. Theoretically, it would be possible to remove a small tumor endoscopically and regard some separate treatment for the neck. But from an oncological standpoint, this is not useful. So I would say we must look at this in a comprehensive manner and not separately.
Any comments from my non-surgical colleagues? Marshall?
Yeah, I think when we look at the total treatment of a tumor, we have to consider what's called package time, which was first identified by a group of radiation therapy people in radiation therapy oncology group. Once you begin a treatment, interruption, delays become opportunities for cancer cells to regrow with partial resistance or with more aggressive behavior. So I think that when you perform the surgery or you start the chemotherapy or the chemoradiotherapy, that you need to be very brisk between the treatments. And I think to do the surgery first, particularly in a small tumor where you're going to have to give radiation in any case, is to really delay a regional therapy and to perturb the treatment, kind of delay the thorough regional treatment. I prefer to think of the induction and chemoradiotherapy, the chemoradiotherapy alone, as treating the entire region and then having, and systemically, and then having the surgery as a way of eliminating the focus of disease, where the bulk of cancer is. If we think of cure of cancer as a probabilistic model in which all other things being equal, the number of cancer cells is really the determinant of survival and cure. Usually the area where the bulk of the cancer cells are where you're going to fail. And so if you have a large neck node, even an N3 unresectable neck node, in our practice what we do is begin with the systemic therapy, go to the regional chemoradiotherapy, and then we have focused surgery to reduce what was previously unresectable in a selective manner. And we think that that's really a more biologically relevant treatment. And then I would also caution that if you have to do a partial treatment and still follow with radiation, you're going to run into similar problems, or even more profound problems in terms of swallowing and breathing post hoc. So I think it's important to really consider that in terms of when you plan the surgery in these patients.
Really, I learned 10 years ago the principal difference is not between T or N stage. I learned from Professor Vermonken the principal difference is between resectable and resectable disease. For me, it's the principal difference for all type of tumor from head and neck cancer. For example, T4 of larynx have a very different evolution with respect to T4 of hypopharynx. But the difference is the possibility of resectability is the key of the question.
Do you think the concept of resectability is very variable among your surgical colleagues, in that you will have the young enthusiasts who will resect everything, and I would call that debulking a lot of the time. It's not necessarily clear margin curative treatment. So it kind of depends on your multidisciplinary team as to, are you all equally aggressive and your determination of resectability is defined, and then your determination of unresectability or untreatability, is that actually defined?
It's interesting that you put it that way. I agree. You know, I think debulking surgery is a complete mistake unless you're doing it to preserve life in the patient. For example, a ball valve airway issue. But in TAC 324, we took into account that, and what we did was we had operable, and then we had resectable with low curability, which is, you know, your more aggressive surgeon. In fact, it turned out that resectable with low curability had the least survival in our group, and I think that reflected to a certain extent that these were large volume tumors that were kind of resectable, but were, you know, borderline really in terms of their treatment. Unresectable disease with encasement of the carotid, invasion of the base of the skull, is not a volume-driven decision, whereas resectable with cure rate is more volume-driven, and that I think reflects the biology of the disease and why the survival was poor in that population. So I agree with you. Resectability is one issue. Resectability for cure is another.
Sorry,
if I can comment, we've taken an approach somewhat similar to Marshall's in that we viewed these advanced hypopharynx cancers as a disease that needs to be treated with an upfront chemotherapy radiation approach. We don't really talk too much in our, at least, tumor conference about resectability or unresectability in that, first, we don't often see an advanced T stage in the hypopharynx without involvement of the neck. We'll see that once in a while, but we hardly ever see the T4N0s, T4N1 of, say, the piriform sinus or other hypopharyngeal sites. So we view these as really a disease that needs to be treated certainly with a multimodality approach and with an approach that would cover both the tumor and the neck at the same time, and that's why we've undertaken mostly chemotherapy radiation. The risk of failure, though, is certainly going to be quite different for somebody who has an advanced T stage versus someone who has an advanced end stage. And there is where we begin to debate whether induction chemotherapy plays a role, where if we recognize that N2B or greater patients have a high rate or a higher rate of distant failure, one can hypothesize that induction chemotherapy may be able to affect that, and that I think was part of the point you were getting to, Ricardo, with the combination of induction chemotherapy followed by chemotherapy radiation.
Petra, have you any comment?
Yeah, for partial resections, yeah, there are criteria for resectability. Yeah, this means, as a rule of thumb, I would say, that hypopharyngeal carcinoma with mobile vocal folds usually are resectable with preservation of function. This is true for T3 carcinomas with mobile vocal folds as well. In T3 carcinomas with fixed vocal cords, things become more difficult. For these, what's the reason for this fixation? The reason might be that the arytenoid cartilage is fixed by invasion of the paraglottic space of the supraglottic or even glottic level. And in these cases, other factors come together. For example, these tumors tend to grow down to the apex of the piriform sinus. Then we might see erosion of cartilage, infiltration of cartilage. And these tumors are not as favorable or not unsuitable for laser resections or partial resections, whereas fixation with just due to fixation of the arytenoid on the supraglottic level, we can do this. So there are criteria. But you are right, we must see the patient together. And even in this group of patients where we did these partial resections, we had 70% of patients presenting with lymph node metastasis at presentation. So you're right, yeah, you talked of 75%. No? So we must regard treatment of the neck separately, no? And go for a selective neck dissection. And due to this high incidence of metastases, many patients need adjuvant treatment as well.
Well, we've taken, so our approach has been a little bit different in that we've said if you're going to expose these patients to chemotherapy radiation anyway, we've decided to do that up front, to do chemotherapy radiation first and use surgery as a salvage, again recognizing that the great majority of patients we see with hypopharynx have stage 4 and certainly stage 3 or 4. So it's, I guess, a little bit of a different philosophy with respect to sequencing the modalities.
I think there are 2 points I'd like to make. One is that we have to distinguish larynx cancer from hypopharynx cancer because of the entirely worse prognosis, the higher rate of distant metastases, the larger impact of lymphatic spread that we see. And finally, I think we need to also distinguish the early larynx cancers from the late larynx cancers and hypopharynx cancers. There is absolutely no data of a robust or significant effect of chemoradiotherapy on systemic metastases, with the sole exception of the 9111 trial, where it wasn't significant, but it was close to significant. I think with both of the arms showing an effect on distant metastases. So if we begin to get good local regional control, what we see in almost all of the studies, including the unresectable chemo-RT studies, what we see is the larger fraction of patients dying actually from distant metastases. This is true of the chemoradiotherapy postoperative studies, which tell us again that giving induction chemotherapy up front, which reduces distant metastases, might turn out to be a better strategy. And is also true of the unresectable cases. And I think if we look at the STAR study of chemo-RT, it's true there, both in oropharynx and hypopharynx, no impact on distant metastases. With cetuximab, no impact on distant metastases. And so, given the consistent results on distant metastases that we've seen with the induction regimens, we have to really think about that as an issue with these patients as well.
Distant metastases have a direct relationship with the next stage.
Yes,
it's direct relationship.
Yes.
In my opinion, the optimal scheme of chemotherapy, of induction chemotherapy, is for local regional control in general. But for example, in our trials, it's possible in all patients with N2, N3, N-stage surgery after chemoradiation or induction chemotherapy plus chemoradiation. Probably for this reason, as Marshall said before, TPF is better than PF in the local regional control. Local regional control in special, but local regional of primary control tumor.
Can I, as a surgeon, kind of carry on with the surgical theme? Because what about patient selection on tumor volume, i.e. a big tumor is distinct from a small tumor? The length of the cancer, we know from a surgical point of view, greater than 5 centimeters in length in hypopharynx is unlikely to be surgically cured. Cord palsy, 1 cord, 2 cords, cartilage destruction. And of course, as I think it was Marshall alluded to, if the patient was aspirating before you started, are they actually suitable for going ahead? Quote unquote, they're still technically operable. Are they curable? So should they actually have their tumor taken away, because you're not going to preserve a functioning organ that is preserved. In other words, you may preserve a larynx, but I'm not so sure they will swallow terribly well.
Now, that hasn't been well followed in the therapy. I think we've been so enthusiastic about finding out whether you could do it at all that we haven't addressed the late complications. Some of those are addressable by post-treatment management. You alluded last night to speech and swallowing therapy, which we have in our own clinic. We dilate our patients, so we get rid of some of the strictures, which helps with the aspiration. But the bottom line is that if the patient is not capable of rehabilitating, then surgery becomes a much better upfront issue. I had a patient that I saw in the hospital. He was 82 years old. He had a trach for T3N0 larynx cancer. And I came up, I was the 3rd person to see him, and I said, you should have a laryngectomy. My surgeon radiation oncologist had said, you should have organ-preserving treatment. And we ended up having to treat him because he absolutely refused a laryngectomy. And in fact, he eventually had his trach out, but he died from aspiration pneumonia. He died from actually hyponatremia as a result of drinking water and then getting pneumonia from his aspiration. So one could say it was unrelated to therapy with the hyponatremia, but it was truly a treatment-related death. And it's these kinds of patients that we really have to kind of think about. 83 is a little extreme, but I use it as an example of one end of the spectrum.
But I agree. I don't think we've done a great job looking at function, looking at long-term function. So we clearly have documented our ability to preserve the organ, but I'm not sure that we've documented our ability to preserve a function.